Good morning, everyone. Welcome to Pediatric Grand Rounds. Today's speaker is Dr. Aarat Patel from UVA. He's a rheumatologist who cares for both children and adults with autoimmune diseases. Dr. Patel received his medical degree from Ross University School of Medicine and completed his internal medicine and pediatric residency at Stony Brook University Hospital. In addition, he completed a rheumatology fellowship in both adult and pediatric rheumatology at the University of Pittsburgh Medical Center and the UPMC Children's Hospital of Philadelphia. His areas of interest include polymyositis, dermatomyositis, JIA, inflammatory eye disease, and sarcoidosis, to name a few. Please join me in welcoming Dr. Aarat Patel.
Thank you. Can you guys hear me okay?
Yep. Yes.
Okay, so I'm going to be talking about juvenile idiopathic arthritis today, and this title slide is a pretty good summary of the entire talk. So we'll start from the bottom there. The bottom photo of the two knees shows one of the most common presentations of juvenile arthritis, which is just a monoarthritis, one joint affected, and the majority of patients will just have one knee or both knees. So when children complain of knee stiffness or there's a swollen knee, juvenile arthritis is, of course, in the differential. The photo next to it is that we always have to remember about uveitis, because uveitis is a part of juvenile arthritis, and some patients with juvenile arthritis actually don't have arthritis, they just have uveitis, and we call them juvenile arthritis mostly to get medications approved for their inflammatory eye disease. And then just like adults with rheumatoid arthritis, we can have children who have a polyarthritis where multiple joints are affected, and it's usually the fingers and the toes. The top two photos there are someone who has a little bit of a different disease. It's not an autoimmune disease, it's an autoinflammatory disease, and that's systemic juvenile arthritis with rash and fever and macrophage activation. And then, of course, the X-ray is there, but X-rays are usually not that useful in our diseases, and you'll see why as we go along. Okay, here are my disclosures. Nothing really relevant to this topic. We won't really be discussing any medications, just classes of medications that we use in our conditions such as juvenile arthritis and systemic juvenile arthritis. So we call it JIA instead of JRA. JRA is a really old term, and the rheumatology community and the medical community has sort of gone away from calling it juvenile rheumatoid arthritis or JRA, mostly because it's very different than adults who have rheumatoid arthritis. In Europe, sometimes they just call it JA, juvenile arthritis. And then many years ago, they came up with this term juvenile idiopathic arthritis. So that's what we call it now, JIA instead of juvenile rheumatoid arthritis. And here are the take-home points for this talk. So this is like the most important slide here, and we'll have this slide come again at the end. Juvenile arthritis is heterogeneous. You don't really have to pay attention to the specific subclasses. I'll go over the subclasses because there's a difference in some of the patients, how they present, and a difference in how they will do. The only subclass to really pay attention to is systemic juvenile arthritis. And normally, we wouldn't even be talking about systemic juvenile arthritis along with regular juvenile arthritis because they're very different diseases. As they share that name, juvenile arthritis, we talk about them together. We don't rely on pain or lab tests to tell us that there's disease. Of course, that's how patients usually end up being referred, is for joint pain and an abnormal blood test, like an abnormal ANA. And the majority of those patients do not actually have an autoimmune disease. The ANA is sort of like the bane of our existence. And if we could make it where only rheumatologists could order that test, it would probably reduce the amount of referrals we get, because most of those ANAs are bogus and don't actually relate to any kind of disease. And pain itself is a negative predictor for juvenile arthritis. The majority of patients have morning stiffness and swelling, and they don't complain about pain. That's why when we see them, they've already advanced in their disease because they're not complaining to their parents, they're not complaining to their pediatricians or their family medicine doctors about pain, because there is no pain until it's pretty advanced. Once we see this disease, we treat very aggressively, because remission is really the only acceptable outcome. These children are growing. They're, of course, different than adults. We like to get into remission with adults as well, but it's even more important in children. But of course, remember uveitis. And one thing about juvenile arthritis is you don't, quote unquote, outgrow it. It does persist into adulthood for a number of patients, but the majority of them we can get into remission and taper off medications where it will not persist into adulthood. Okay, so juvenile arthritis is a chronic arthritis. It's the most common chronic rheumatic disease of childhood. It's actually more common than type 1 diabetes. And it's an important cause of disability. We're trying to prevent this from happening by treating aggressively. And there's many different classification systems, which we'll go over. The definition of the disease is you are... a message here. I guess I'll just approve it for... Okay. There's... you're usually 16 years or younger. That doesn't mean a 14-year-old can't get rheumatoid arthritis, and it doesn't mean a 20-year-old can't get juvenile arthritis. It's really how they present. They have to have inflammation in a joint for about 6 weeks. So if we get a phone call that someone has a swollen knee for a week, chances are it's been swollen for longer. But if it's a really good historian and they say it's only been swollen for a week, we're not going to call that juvenile arthritis, because it could be a reactive arthritis, or it could be an injury, it could be something else. So of course you can't have another cause to have the diagnosis of juvenile arthritis. And the onset type is defined by how many joints they have in those first 6 months. So if you come in with a rip-roaring inflammation in all of your small joints of your hands, then we're going to say you have a polyarthritis. If a child only has 1 or 2 joints, we're going to say they have an oligoarthritis. And if they come in with the characteristic fever and systemic rash, then we will say they have systemic onset juvenile arthritis. And there's a bunch of other forms of juvenile arthritis. Sorry, I wasn't able to advance. And this is a really old classification criteria. It's over 20 years old. And this goes through all these different classifications, which it doesn't really matter. I'm just going to go over them. So this is what we're talking about today. We're talking about oligoarthritis, which is less than 5 joints, and polyarthritis. And then there's something called spondyloarthropathies, which is a completely different topic. Very similar treatments, similar presentation, but there's usually psoriasis in the children who have psoriatic arthritis. There's inflammation of tendons and ligaments in people who have enthesitis-related arthritis. And then there's one called undifferentiated arthritis, where you don't really fit a category. The patients who have enthesitis arthritis, or enthesitis-related arthritis rather, could have inflammatory bowel disease. So inflammatory bowel disease-related arthritis fits into spondyloarthropathies and behaves like psoriatic arthritis and enthesitis-related arthritis. And again, it's a completely different topic. So to make it easier, we get rid of whether you had 5 joints within 6 months or 6 joints at month 7. So it's either oligoarthritis, polyarthritis, the spondyloarthropathies, and systemic JIA, which is an autoinflammatory disease. So we're going to really be talking about juvenile arthritis, which is patients who come in with a few joints or multiple joints that are inflamed. And then I'll touch upon systemic JIA because it's important, but we're not really going to be talking about spondyloarthropathies as much. The big difference between spondyloarthropathies and juvenile arthritis is inflammation of the spine. So our patients who have juvenile arthritis will not have inflammation of the spine. Patients who have juvenile psoriatic arthritis or juvenile ankylosing spondylitis, which are spondyloarthropathies, can have inflammation of the SI joints. Some of those patients, of course, do have inflammatory bowel disease. We don't really need to pay attention to all of these subclasses, though. The most important thing to pay attention to is systemic JIA. So the first 6 months of disease, how many joints they had affected, is really not that important because we're treating aggressively. So we're hoping at 6 months, these patients are in remission. So there's a few questions in here and a few cases, and it'll kind of help us differentiate the different types of arthritis. So here's a classic case. A 3-year-old female is brought to the office with left knee swelling. The parents are not sure how long this has been present. You suspect juvenile arthritis. So this girl is holding her left leg out, and it's bent because of the swelling, and there's a little bit of a leg length discrepancy, which tells us that this inflammation or swelling has been there for quite a bit. So what are important labs to consider? We have the ANA, the rheumatoid factor, the CCP antibody, the ESR, and the CRP. So in reality, none of these.
That's your question.
And the reason none are important is because although the ANA would be the answer to the board question, because this does show up on the American Academy of Pediatric boards, the other ones are not important. The only reason the ANA is important in a child with juvenile arthritis is it tells us the chances of them having uveitis. So if you have a positive ANA, there's a higher chance of having uveitis. The rheumatoid factor is positive in less than 5% of children who have juvenile arthritis. So it's pretty useless because if it is positive, it's most likely a false positive. The CCP antibody is more specific for adults with rheumatoid arthritis. So when it's positive, it doesn't really tell us much in children. And then the markers of inflammation, they are normal in the majority of children who have oligo-JIA, and they can even be normal in someone who has poly-JIA. So it's not reassuring when someone has a normal ESR and a CRP because they could still have inflammation in the joint. And we, of course, have a problem with obesity and childhood obesity now, and that leads to a positive ESR in a lot of patients. So the ESR and CRP, we will check them when we're suspecting systemic JIA along with a ferritin, but in someone who has a swollen knee, it's really not that important. So the labs are not that important. Of course, we're not thinking outside of the box here. We're not thinking of leukemia and infection and other things. So it's not like stop getting labs completely, because some patients, of course, need a CBC and they need markers of inflammation. But when we're looking at someone when I see a patient for the first time with an inflamed knee, I usually don't get blood work. One, I don't want the children to associate me with blood work. So I'll have them go to a lab with their parents, and this way they don't not like me and they just, don't associate me with getting labs. But two is really because they're not going to help us diagnose. So we don't rely on labs. The ANA is positive in about 65 to 85% of patients. Those are the ones who have a higher chance of uveitis. 90% of juvenile arthritis kids have a negative RF and a CCP. Oligo-JIA rarely has elevated ESR and CRP, as I said, and poly-JIA can have destruction in their poly-JIA patients can have destruction in their joints, but will have completely normal labs. So this is the classic finding in a patient who presents with juvenile arthritis. All of these patients, some were seen in Richmond, I can tell by the paper on the table, and some were seen at UVA. All of these are the first visit. And these patients actually didn't have that much pain. Their parents noticed limping in the morning, and that is coming from stiffness, and they eventually notice swelling. But this swelling didn't occur overnight. The girl on the right, and she's also in the middle photo, her knee has a flexion contracture, and it's not actually synovial fluid, it's bony prominence. So the bone is hypertrophied, and there's something called synovial hypertrophy or synovial thickening that occurs of the lining in between the joint, and that takes months to occur. And then the boy on the left, both of his knees have this. The one on the right is worse, of course. So you decide not to get labs. You obtain a history instead. What are some signs and symptoms to expect? Left knee pain, morning stiffness, fever, or rash. So we know the answer to this now. The answer is morning stiffness. These children will not have much pain unless you really try to bend their knee and there's a contracture. Of course, there's going to be pain then. And they will not have fever or rash. You'll have fever or rash in systemic JIA, and this is not systemic JIA. So we don't rely on pain to tell us that there's disease. Pain is a strong negative predictor of inflammatory disease. So when we get the teenager who comes in with head to toe pain, they're sent here and sent to other specialists to make sure they don't have an infection, they don't have malignancy, they don't have an autoimmune disease. They usually have a pain syndrome and they don't have an inflammatory arthritis. When someone has that much pain and a very normal exam, they're not going to have an inflammatory arthritis. And juvenile arthritis is really determined by a careful physical exam. Not much imaging doesn't help too much. We get the imaging to see if there's damage in the joints, but it doesn't really help initially. So talking about oligo-JIA, it used to be called Pauciarticular. So this is when you have only a few joints affected. This is about half the patients with juvenile arthritis. There's morning stiffness. It's mostly the large joints. So close to 90% of these patients will come in with just one knee or both knees affected. An isolated hip joint is very rare. So when there's a child who can't move their hip joint, in a younger child, we're thinking toxic synovitis. Those patients don't even end up coming in to see us. They're usually better by the time they have their appointment with rheumatology, and they'll usually go to ortho. Systemic symptoms are absent in the patients who have less than 5 joints, and this category puts you at a higher risk for uveitis. And a lot of those patients are asymptomatic. 3 or 4-year-olds not going to complain about blurry vision. Even the older patients who could complain about blurry vision, it could be an asymptomatic inflammation in their eye. So we always have them see ophthalmologists periodically. And this is the peak of these patients. So you'll see in juvenile arthritis, there's a peak at right around when the patient turns 1 or 2. This is representing females as the highest there. And there's there's a second peak that occurs in teenagers, which is not in this graph. So you're almost certain that the diagnosis, but want to confirm it with an imaging study. So the best imaging study would be plain X-ray, MRI without contrast, MRI with contrast, or a CAT scan. So the next study, if we're doing board exam questions here, they always trick you with the next or the best. I don't think they're allowed to do that anymore, but they used to do that when I was taking board exams. So the next study would, of course, be an X-ray. You have to get an X-ray because insurance mandates you to get an X-ray before you get an MRI. But the best study is an MRI with contrast. And the reason it's with contrast is the contrast lights up the synovium, and it really helps us identify that this is an inflammatory arthritis. Most orthopedists don't use contrast. Most rheumatologists do use contrast. It's because we're looking for entirely different things. So sometimes we'll get someone who's already seen ortho and they had an MRI and it may have not been completely clear. We do repeat the MRI as long as insurance lets us with contrast sometimes. And those are only in the children that we really need imaging, because this is a clinical diagnosis. The knee is going to be warm, it's going to be swollen, and the history is going to be that there's morning stiffness. So we don't usually need an MRI, but if we had to do one, we would do one with contrast, and that's the best study to show inflammation in a joint. And you can see here in the films, the bottom right is the MRI showing the synovial enhancement. If we do find X-rays, if we do have any X-ray findings, excuse me, it would be soft tissue swelling. Maybe some periarticular osteopenia. This is something we see in adults with rheumatoid arthritis. We'll X-ray their hands, and there'll be periarticular osteopenia around the MCP joints and the PIB joints from inflammation. Erosions are rare in children, but if they are present, then we know we have to be aggressive. And there'll be a little bit of loss of joint space in the X-rays. This is showing that the two on the left there, the knees, it's showing a normal knee and an abnormal knee. You see the joint space loss. The film in the middle there is the film in the middle is showing some joint space loss as well as a little bit of bony prominence and periarticular osteopenia. And this is an MRI finding. And the MRI finding, you'll see, a large knee effusion, marked inflammatory synovial hypertrophy. Now, this person did not need an MRI. They probably had a clinical exam that was pretty obvious of what it was, but maybe someone's suspecting some kind of tear, and that's why they got the MRI. So something that's important is other causes of monoarthritis, because not everyone's going to have juvenile arthritis. So some of the other causes, what are some other causes of monoarthritis that we should consider in a patient like this who comes in with a swollen knee? We have Lyme arthritis, we have post-strep arthritis, we have parvovirus, we have Lyme arthritis and post-strep arthritis, or all of the above. So when we have a patient who comes in with Lyme arthritis, the history is very different than JIA. The number one finding in someone who has Lyme arthritis is episodic swelling. It'll look exactly as it did in the photo I showed, but these patients will not have synovial hypertrophy because their joint is usually swollen, and then it resolves. And then it swells up again a few weeks or months later, and then it resolves. Usually the second or third time it swells up, the parents bring the child in, and when we hear that history of episodic swelling, we suspect Lyme arthritis. Post-strep arthritis is a little different. Post-strep arthritis will cause swelling in one joint, and then it will migrate, just like other reactive arthritides, to a different joint. But when the patient comes in, they're only there for 10 minutes, 20 minutes, it's swollen. So we have to get the history of, hey, was the ankle swollen? When the ankle moved to the knee, did the ankle resolve? Because that's what happens in a reactive arthritis. So the answer is D. It could be A or B, or A and B. It could be Lyme arthritis or post-strep arthritis. We have to just get the history. The reason it's not parvovirus is in older children, so in teenagers and young adults, when they have parvovirus, they usually have a polyarthritis if they're going to have inflammation in the joints. So parvovirus, when adults come in with their fingers swollen, parvo is in the differential because parvo will cause a rheumatoid arthritis-like picture. The larger joints, like the knees, are affected in Lyme and post-strep arthritis, or even rheumatic fever, of course, but parvo is usually those smaller joints in older children. So the answer is A plus B. But now we're gonna switch over to a patient with polyarticular JIA. So we have a 15-year-old female who presents to the ED with a few weeks of polyarthralgia, most recently polyarthritis. Arthralgia just means joint pain. Polyarthritis means inflammation in the joints. So we have the small joints of the hands as well as the wrists, elbows, and knees are affected. There is morning stiffness, there is fatigue, and there is some weight loss. So what are some diseases to consider, and what are some important labs to obtain? So in someone who has polyarthritis, we're worried about, of course, autoimmune disease. We're worried about some kind of infection because we don't know how long this person has had this polyarthritis. And we're worried about malignancy because they're complaining of pain sometimes and there's no actual inflammation in the joint. So it might even be bony pain like we would see in a leukemic process. Important labs are the usual CBC, CMP, markers of inflammation. The reason to check a UA is if someone comes in with a polyarthritis, we're worried about maybe a lupus-like picture where they may have proteinuria. So the UA is important. And in this patient, the rheumatoid factor, the CCP, and the ANA may actually be a pretty good study to do because, again, they could have lupus or they could have rheumatoid arthritis as a teenager. The LDH and the uric acid is something we get done to help with ruling out leukemia or lymphoma. We're not usually worried about gout, so we're not getting a uric acid for that reason, because usually children, are not going to get gout unless there's something genetic going on. And then there's infectious causes, right? We got the parvovirus, different types of hepatitis, GC, and chlamydia. And then in our differential, we of course like to see, we like to think of other autoimmune diseases. So the girl on the top left has a polyarthritis, but she also has inflammation of her knuckles. So this patient has dermatomyositis and muscle weakness. The patient on the right has these vasculitic ulcers as well as proteinuria. So the patient on the right there, bottom right, has lupus along with a polyarthritis. So it's not just polyarticular JIA. It opens up a lot of other conditions. So about a third of patients, juvenile arthritis, will have polyarticular disease. Here we have more systemic features. There's a little bit of fatigue. There's morning stiffness. Large joints and small joints can be affected. It's more of a symmetric disease, so it's not just one knee. Here, there's usually not spine involvement in the lower spine, but there can be cervical spine involvement with loss of extension, something we don't usually see in adults with rheumatoid arthritis. And we can have TMJ inflammation. And this is really important because it can also be asymptomatic. So patients won't complain about morning stiffness when they're brushing their teeth or when they're eating breakfast. So we have to really look for that TMJ arthritis, unless patients with this have inflammation in their eye. Here, there could be lab abnormalities. So we could have rheumatoid factor CCP and ANA positive, and we could have an elevated marker of inflammation or an elevated white blood cell count. And there can be more destruction of the joint. Here, these x-rays show that the x-ray in the middle there shows, complete destruction of this carpal area and the MCP area from inflammation in the joints. So these are the two types of inflammatory arthritis. We're not going to talk about systemic GI just yet. I just want to touch upon management and treatment of juvenile arthritis. Some patients who have had significant joint deformity and have had disease for a while before it's treated would benefit from physical therapy and occupational therapy. The goal is always to get them back to school if they've missed any school. The majority of our kids do not need 504 plans because we can treat them very aggressively and quickly and get them right back to school. Of course, there are some rare cases where our treatments don't work. And for those patients, a homebound or cyber school or I forgot what they call it now, virtual school is necessary, but we really try to keep them with their peers if possible. And one of the things we use the most is NSAIDs, but NSAIDs don't really cure or treat our diseases that effectively, but they're a great adjunct to therapy. So we always start our patients on naproxen if they weigh enough, 500 milligrams twice a day. It's usually 10 milligrams per kilogram twice a day, and that's our go-to initial treatment. And then we have different DMARDs and injectable medications, biologics that we use, and infusions that we use. This is the infusion suite at St. Mary's in Richmond. So the common goal, suppress inflammation and prevent disability. We want to maintain function, and we can do this with as little risk as possible because our medications are very safe. Of course, if you read the prescribing information, they don't look safe at all, but they are in fact very safe, and they're much safer than prednisone. So we're trying to foster normal social, psychological development. Sometimes we need OT and PT, and we want them to play sports. We want them to exercise just like their peers. If we do use NSAIDs or steroids, we're trying to minimize the amount of steroids we're using. NSAIDs we can use for weeks and months with very little adverse effects, but steroids, of course, have a lot of adverse effects. So we're trying to keep it to a month at the most of steroids, and that's usually with a taper. Methotrexate is our anchor drug. The majority of our patients who have juvenile arthritis will be started on methotrexate. We can give this by mouth. We can inject it once a week. The injections, of course, are more effective because they're absorbed better and they have less GI toxicity. And the methotrexate we use is a fraction of the dose that our oncology colleagues use. So we're not usually looking at many adverse effects. It's usually just the nausea the day after they take it. And if that occurs, we usually switch treatments. We don't want our children to be nauseous once a week. And sometimes we add other DMARDs like sulfasalazine or hydroxychloroquine or leflunomide. We'll usually not give them too many of these pills all at once, because if they're starting to need multiple DMARDs, it's much better just to start them on a biologic agent. So this is our treatment algorithm. NSAIDs will work for about 10 or 15% of patients. So every now and then we'll have a child who has one knee and it's pretty mild, where we will just keep them on naproxen and they won't need a steroid injection, they won't need DMARDs, and they won't need biologics. Steroid injections themselves used to be used a lot more than they do now. So some of our patients who are in their 20s, that's how they were treated. They were treated with steroid injections every 6 months. But there's some joint damage that occurs with that, and it doesn't put people into remission. So we really don't use these as a primary form of treatment anymore. It can reduce the use of DMARDs, but most of them patients have to be put on methotrexate, sulfasalazine, leflunomide, or hydroxychloroquine. And when they're put on these DMARDs or these biologics, and this is just going through the different classes of biologics, what they are is not as important. There's so many of them. Different ones come out every year for rheumatoid arthritis, and then a study's done in juvenile arthritis, and we start using them. The important part is we put these patients into remission. Once they're in remission, we keep them in remission for about a year, sometimes a year and a half, and then we slowly back off on treatment, and a lot of the patients don't need treatment after that. So it's like a 3-year relationship, 4-year relationship, hopefully, with these patients, and then I never have to see them again. Some of them, of course, are refractory to tapering, and we'll have them on treatment for many years. But the goal is always to grow normally without any kind of joint deformity, and the majority of patients can achieve that. And then as they become adults, only about 80% of them will be completely off treatment into adulthood, 80 to 85%, depending on the study. So one of the goals, this is one of the take-home points, treat early and aggressive, because remission is the only acceptable outcome. So going back to that first patient, this is a leg length discrepancy. Now, luckily, this patient is young, so will grow, and hopefully there'll be some catch-up growth in that right leg. But the picture on the right is someone who has had TMJ inflammation, who will eventually need some kind of joint replacement or surgery. There's micrognathia from that TMJ inflammation. We're trying not to cause adverse effects. The majority of our drugs do not do this. So this was a study done in Boston. DMARD toxicity in children, very rare. 305 patients, no chronic toxicity, no measurable increase in infections on patients on methotrexate and TNF inhibitors, and no measurable increase in cancer. So there's that black box warning on our TNF inhibitors. It's a completely bogus warning. 20 years of studies now in rheumatoid arthritis patients have shown that the rheumatoid arthritis patients who are put on TNF inhibitors like etanercept or adalimumab or infliximab have a lower chance of malignancy than the ones who are not put on these, because we're sort of fixing the immune system. So the black box warning is really there because the RA patients themselves have a higher risk of malignancy than the general population. So we're trying to, this number, of course, is a lot higher now. So it says 55% will have active disease. Actually, it's a lot lower, excuse me. It's more like 20 to 30 now will have active disease as they go into adulthood. There's no cure, but we really put these patients into remission, and that's the goal. So you're seeing a patient with juvenile arthritis complicated by uveitis. The characteristics of disease This one's a little tricky. So monoarthritis with a positive ANA, monoarthritis with a negative ANA, polyarthritis with a rheumatoid factor that's positive, polyarthritis with fever and rash. So the patients who have less than 5 joints and the patients who are positive ANA are the highest likelihood of having uveitis. The other choices, so we have a polyarticular patient, we have a systemic JIA patient, and then we have just a patient with less than 5 joints who has an ANA negative. Again, the ANA is not that important because all these patients are going to the ophthalmologist. They have to make sure that they don't have uveitis. The reason they all go to the ophthalmologist is because many of these patients will have no symptoms. And this usually occurs in the first few years of disease. So if they've had disease for several years, they could probably stop going to the ophthalmologist. But 65% of these patients will have no symptoms. No pain, no vision change, no photophobia. So it's really important for them to see the ophthalmologist every 3 months, every 6 months, depending on what their risk is for uveitis. And the treatment is similar. So we do use biologics. We use off-label biologics. We have one that's FDA approved now. We use methotrexate, and we're trying to prevent steroid use here again. So steroid eye drops are great for uveitis in the beginning, but if you're on them for a long time, they can cause significant amount of side effects. So methotrexate is a lot safer than topical steroids, more than 1 drop a day. So we're going to talk a little bit about systemic onset JIA now. Very different disease. It's an autoinflammatory disease that has to do with the innate immune system rather than being autoimmune, such as lupus or juvenile arthritis. These patients have fever and rash, and some of them don't even have inflamed joints. There's these systemic features: lymphadenopathy, hepatosplenomegaly, and uveitis and arthritis can be uncommon. And the most common symptom, of course, is fever. You have these fever spikes. It's daily, late in the evening, early morning. We call that the quotidian pattern. And the fever comes back to normal. So if you have fevers all day, we're more worried about malignancy or infection than systemic JIA. If you have fevers once or twice a day, every day, we're worried about systemic JIA. And usually during the fever is when you get the rash. You can have the rash outside of the fever, but the rash gets worse during the fever, and the kids feel awful when they have the fever. So this is an 8-year-old patient with systemic JIA, and some of the things are circled here. So he has lymphadenopathy, he has hepatosplenomegaly, he has large joints, the knees and the fingers, small joints affected. And this is a patient with the salmon-colored rash. The lesions are transient. They occur in crops over the trunk and extremities. They may occur in a linear distribution after minor trauma. We call that the isomorphic response. So when I first see a patient where I suspect juvenile arthritis, or systemic juvenile arthritis, we'll scratch them and we'll see the rash appear where we scratch them. We call that the isomorphic response. So this girl scratched her face and the rash appeared. And the labs here, so most of these patients will have an elevated ferritin, but not everyone. Some of them will have an elevated ESR, elevated white blood cell count. The ANA and the rheumatoid factor could be negative. They could have an elevated D dimer. And there's a lot of extra-articular manifestations. So some of these patients could have hepatitis, hematuria. They could have a pulmonary fibrosis or an interstitial lung disease. We could have pericarditis, myocarditis, growth disturbances. The treatment is different, as in some patients will actually go into remission just on NSAIDs. Patient could be admitted for a few weeks to the hospital with daily fevers. We start them on 500 of naproxen, and they're like a new person, and they go home. Some of those patients will progress, and they'll need steroids. Some of them will need an IL-1 agent or an IL-6 agent. These are the mainstay of our treatment. Methotrexate doesn't work as well in these patients unless they have joint involvement. It usually doesn't work for the rash and the fever. Okay, so here are the take-home points. So juvenile arthritis is heterogeneous. We don't have to pay attention to the specific subclasses except for systemic JIA. So if we have a patient who has inflamed joints or who has joint pain and has fevers and rashes, different disease, similar treatments, but different disease. Don't rely on pain or lab tests to tell us that there's disease. So if there's a patient who wakes up stiff in the morning and parents are complaining that they're limping a little bit in the morning, that patient is more likely to have juvenile arthritis than someone who has pain all day. We want to treat early and aggressive. It's nearly impossible to get in with a pediatric rheumatologist in less than a few weeks, anywhere in the state or the country. So most people have my cell phone number. They'll text me, they'll call me and say, I think I have a kid with juvenile arthritis, and we just see him at lunchtime as soon as we can, either in Richmond or at UVA. So as soon as you suspect juvenile arthritis, we try to get those patients in as soon as possible. If someone has head to toe pain, we usually know they don't have juvenile arthritis. Those patients may not need to be seen as soon as possible. And remember uveitis. So our patients see us every 4 months when they're in remission. Some of them, they do show up sometimes, so every 6 months. So it's a good idea for primary care physicians, if the patient has juvenile arthritis, just to ask them, hey, have you seen the ophthalmologist recently? Because uveitis can cause blindness, of course. That's why it's important. And some of these patients do persist into adulthood. You don't grow out of it. We try to put them in remission, keep them in remission, and then slowly ease off our treatments. And some of those patients don't need to be on treatments anymore, and that's great. And then we don't need to see them anymore. But sometimes you do persist into adulthood. I think that's it.
Dr. Patel, I want to throw in a question. Can you speak to uveitis without arthritis? Is that a thing?
Yeah, so the question was uveitis without arthritis. There's a lot of patients, we have both children and adults, who will have an idiopathic uveitis, sometimes a retinal vasculitis, and the ophthalmologist will do the usual labs, the ANA, the rheumatoid factor, the HLA-B27. Sometimes they'll check for syphilis, and all of this stuff is negative. And even when it's positive, there's no clinical disease. So we don't find inflamed joints. We don't find lupus. We don't find Sjogren's syndrome. So those patients really just have their immune system overactive, causing eye inflammation. So we treat them similarly to our juvenile arthritis patients and our rheumatoid arthritis patients with the same medications. The reason they end up seeing us and not just staying with ophthalmology is the majority of ophthalmologists are not comfortable with these medications. So we do the treatments, but we are not actually looking at what we're treating. The ophthalmologist usually will tell us, okay, there's 1+ cells, there's 2+ cells, there's 3+ cells. So it's a communication between the ophthalmologist and the rheumatologist, where we're treating the inflammation in the eye and they're actually telling us how much inflammation there is. Those patients, we usually like them in remission a little bit longer before we back off on treatment.
Dr. Patel, can I ask, during therapy for JIA, how do you determine success or not success of the therapy and the progression of therapy and also maintenance, particularly with biologics?
So the question was, how do we know that a patient is responding to treatment? It's really the clinical exam. So the first thing we ask the parents and the child, how do you feel when you wake up in the morning? There should be no stiffness. If there's stiffness, it should be like a minute or two. It should not be an hour or half hour. Then on my exam, we move all the joints around in all different ways. And if there's any kind of flinching or any kind of discomfort, then that joint is inflamed. Of course, if it's obvious inflammation where it's warm or has a joint contracture, then we know the medication is not working. We'll give methotrexate about 2-ish months to work, and then we will go to a biologic. And most children will respond to that first or second biologic, I should say first biologic, and then we have some who are just refractory to treatment. Some of that is from non-adherence, but most of the time they're pretty good about taking their medications, even though they're shots, because it makes them feel so much better. And then that's how we can tell if they're in remission or not. And once they're in remission, I tell them we're in remission and everyone's happy. And we're going to stay like this for about a year before we even think about tapering off the medications. And then we taper off real slow. So if you take adalimumab or abatacept every 7 days, every 14 days, you will start to take it every 21 days. You do that for a few months, and you take it every 28 days. And then the patient will know, oh, my knee's a little stiff since I'm taking it every 21 days. Then we know we got to go back to every 14 days.
Dr. Patel, can you speak a little bit to how, from a primary care perspective, we monitor patients who are on treatment for JIA, on maybe biologics?
Yeah, so the biologics, they're actually very safe medications. You know, you read the prescribing information, you see the commercials and all the stuff that shows up on these commercials for these medications. So it, of course, scares people, patients especially, and parents. They're actually very safe. We check a CBC and we check liver function and kidney function about every 4 to 6 months. So we don't even check it that often. And that's really all we have to do. We check a TB test once a year. That's more for insurance wanting us to do that. TB is, of course, not really rampant in this country. You have to do a TB test prior to starting these medications just because of the reactivation of TB from TNF inhibitors. And because TNF inhibitors are known to do that, all of the biologics sort of have this label on them that you should check a TB test. And we usually just do a quantiferon gold. We don't do a PPD. So there's not that much for the primary care physician to monitor. If someone gets a fever, we hold the biologic, we hold the methotrexate until they're better. We have, I guess, a shorter fuse to start an antibiotic in someone who's on a biologic. But in reality, I tell patients this, because this is what's shown in all the studies. If there's 100 of you, 3 or 4 of you may get a UTI or a cellulitis or a pneumonia or something like that. So the chances of you getting an infection are actually pretty slim. But when they do get an infection, you know, we don't love to overtreat with antibiotics. So I maybe write 1 or 2 antibiotics a year. So it's really not a lot. But if someone's on a biologic, that's the only thing that I think about. Well, okay, this might actually be a sinusitis or something like that that needs antibiotic. And then with COVID, in the beginning, we thought you're on a biologic, of course you're going to have a higher chance of being hospitalized. In the first few studies showed that wasn't true. Then the next few studies and this is mostly adults with rheumatoid arthritis who are on these drugs, showed that there is a higher chance of hospitalization from certain biologics. The B-cell agents like rituximab, which we don't use in juvenile arthritis, but we use in vasculitis and lupus, there's a higher chance of being hospitalized. All of that is adult studies. The majority of our children, and I'm also talking about the pediatric nephrology children who are on CellCept, they have done fairly well despite having COVID, and some of these are unvaccinated children. So it's not something that we're not doing anything different while we're thinking about COVID or other infections.
All right, I think that's it, Dr. Patel. Thank you so much for sharing your time and expertise with us. We'll be in touch, I'm sure.
Okay, thank you.
Dr. Patel.